yeah, so we're looking at this eye with melanoma. So I thought these were all spindle B. I didn't think that there was any melanoma epithelioid cells here at all. Yeah.
Good.
I
Other
wasn't
factors?
by vascular arcades here though. They're pretty cool.
They're very good vascular arcades in that they make a complete circumferential loop around nests of melanoma cells. I won't go any higher because it won't render for me. Other factors to consider. So we did the morphology of the cells. We did staging, which is prognostic factors. I would look down here in the sclera to see if there is any scleral vein involvement, and I don't think there is, and there's no episcleral involvement, so we don't have that either. Then if we move on to other prognostic factors, I would do immunohistochemistry for BAP1 on this paraffin section, and I would also send it for FISH for the same things, for chromosomes 3, 6, and 8, the uveal melanoma panel.
The only other thing that I would have commented on is that Brooks membrane is intact, so
Yes.
there is in fact no vitreal invasion.
So how do we know Brooks membrane is intact?
Well, I could actually see it at high power, but it's just the fact it's not mushrooming at low power gives a really good...
It doesn't have that, the caps of the mushroom coming in. It would look dome-shaped, which is why I mentioned the shape in the beginning part. And where's Brooks membrane? It's this one.
Yeah, it's
oh, I can't.
Keep going over
I can't see it. It's part of the retina.
Yeah. But where the retina finishes, it becomes
yes.
like, yeah, just around there. Yeah. So it's actually intact. So there's a bit where the retina's frayed away, but you've still got Brooks membrane over the top.
Yeah. And the clue is it's still smooth.
Yeah.
So the worst prognostic factors about this thing, I think, are its size. Okay,
so Sam's asking what extracellular matrix pattern terms can we use?
Extracellular matrix loop pattern present. That's what I would say. How would you say it, Diane?
Yeah, I would say that as well.
We can see it at this power.
So, okay, let's do the next slide, shall we?
And I'm going to stop here. Hang on. Pause. Stop here. Good.
Okay, so
I will monitor the chat.
Right, so we'll go to breakout rooms again. So we're going to do slide 2 now, unless anyone's got any questions about that slide.
So Diane, so I think a few of us thought there was actually epithelioid. I'm just looking at the slide. I can see, maybe it's to me, but I can definitely see those round shape.
Okay, do you want to share screen and show us?
Yeah, I was trying to do that before, but here we go. Let's see. Can
Here's
you see my screen?
You're coming.
Yeah.
Oh, nice. Oh, you've got much better rendered.
So can you see my screen? Sorry.
I can, yeah.
Yeah. So, oops, what happened?
So I don't think those are epithelioid, because I think those are the standard spindle beads cut the other way, the fascicles coming out of the page. Remember how different the epithelioid cells looked? They were like 4 times as big as your standard spindle cells. So they would, if you just go up a tiny bit, up, 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 up. There we go. There's some really big cells. Just if you stop there,
yeah.
Just about at 7 o'clock, there's some bigger cells.
Yeah.
Keep going.
This one here.
That one there. Okay. So imagine if you had a whole lot of those and lots of cytoplasm. So the nuclei are going to be really big, much bigger than the spindle B cells.
Oh, I see. Because I think that's
that single cell is getting to look like epithelioid.
So in a question exam question, I mean, will that fail us if we thought these were epithelioids?
No, what you have to state is 0 to 10% epithelioid cells. Okay, so that's the classification. It's less than 10%.
So you might have 5% here, Moaz.
Yeah. Okay.
Yep. Great.
Okay.
Sorry, I'm still hanging on the cellular matrix thing. Do you guys ever because it asked about other stains and stuff. Do you use PAS to staining to look at that?
No.
Oh,
Okay.
I do.
You
So-
do PASs on the eyes?
only for that vascular matrix thing.
Okay. I
Yeah.
just look at it.
Like that one, you wouldn't need to because it's obvious. So,
Yeah.
mm.
And like, because you talk about loops, and like in my textbook it says there's like 9 patterns, but it doesn't actually say what they are. Do you sort of have like buzz terms you use, like?
No,
Okay.
present or absent.
Sweet.
Yeah.
I think that's a research paper, so they have to get, you know.
Yeah.
Anyway, let's go look at some more slides.
Let's go. Yeah, let's go to the breakout room and look at the next slide. So I will create them all again. Let's hope it reassigns you randomly.
Do you want me to do the timer, or you've got the timer under control?
Yeah, I'll do the timer. That's all right.
Okay.
Here we go.
So the meta learning skills that we're doing here is a bit of spaced recall and retrieval practice. Yeah.
Yeah, because hopefully you did the Kura Cloud, and now we're getting you to recall and apply, which is good.
Yeah. Who did Kura Cloud for the melanoma? Yeah. Hey. Cool. All right. So those who haven't, there's a video in there, and you can hear me telling you about it all over again. It's a different one.
Okay. So do you want to run the chat, and I'll
Yep.
and I'll share the screen.
Yes.
Melanoma. So what things did you guys find difficult?
I'm just looking at the chat. Where did the chat go? View is exit full screen. So we had some technical issues, couldn't load, and there was not enough time. Yes, there is enough time. You have to prioritize. That's why we give you the time frame.
You will.
So Lucy's got a good question.
That's okay. Yep.
Yep. Same again. Is it arising from the choroid or the ciliary body?
Yep. All right.
And differentiating epithelioid from spindled.
Yeah. Okay. So so looking at this tumor, we can see this dome-shaped lesion that's about, I don't know, 12 millimeters in size, and the midpoint of the base is here or here. So where does the ciliary body end? It probably again arises just here, almost at the equator. It infiltrates the ciliary body for sure. And did you all see that it infiltrated the trabecular meshwork?
I think some people having difficulty rendering a high power. So this is something you can go back and look at the slide and look at that yourself.
So I'll see how we're doing actually here. So this is the trabecular meshwork, and the tumor cells are clearly in it. Yeah, though the other angle looked completely normal. Was there an area, what is that little piece? I can see the thing. What is that little piece of tissue here? Okay, so this is the remnants of the lens here.
How come we don't have the center of the lens, Diane? Where did it go?
So probably when the eye was submitted, the lens was here, but the lens is quite difficult to cut because it's a different texture to the rest of the eye when the histotechs are cutting it, and it kind of chunks out. So you sometimes don't get the lens included if we want to get a really good picture of the tumor. Was there an area near the ciliary body that looked like eosinophilic necrosis? couldn't see any necrosis, to be honest.
There was hemorrhage into the tumour.
Yeah, there's little bits of hemorrhage.
Mm.
This tumour, all right, who thought this was mixed?
Okay, yes. What, type into the chat box. Do you think it's epithelioid, mixed, or spindled? Let's see what the crowd sourcing says.
Yeah, mixed. Yeah, good, good. So these bits here, there were some nice epithelioid cells in, and also probably a few around here. So again, this is a tumour that has got, you know, two components to it. And if we looked down here, we can appreciate at low power the vascular, medium power, the vascular arcades. And these look like pretty good spindle B cells through here. And if you look at the nuclear size and the crowding and the size of the cytoplasm, they're quite different to the cells through here. We were starting to get that typical fried egg epithelioid look with the really giant nucleoli. This hasn't completely rendered, but this is a great epithelioid cell here. Yeah.
I think this is a really good point that you've made, Diane, is it's quite heterogeneous and you have to sample in different areas in order to make that decision.
That's right. So here, is it more or less than 10% that someone's asked? So I would have probably guessed if that's 10%, if that's the area, and there's a little bit down here, I think probably we're going up to about 15 here. So I would say it's more than 10% epithelioid with this one. Are there any other things that, yeah?
And sorry, can I just ask, so in the exam though, we'll just get photos. So
Yeah.
How can we possibly comment on whether there's over 10% involvement, or we just clearly write that?
Yeah, so from the photos that we've been given, there is.
Okay.
You can only deal with the material that you have.
Would you mind just zooming in on that piece of tissue just at the top of the dome? I was just wondering, is that retina?
This bit here?
Yeah, Nishana, no, the yeah.
Yeah,
Because
sure.
we're wondering, is it iris or retina? And we thought maybe it's necrotic retina.
We can see the nuclei from the ganglions. Yeah, this is the outer nuclear layer here. This is kind of gliosis and a mixture of nuclear layer cells and things. Yeah, and again, we've got a clear boundary to the tumor here that looks like Brooks membrane. Okay.
So, sorry, Diane, is there, just by the tubercular meshwork, we were just ask whether, just by the angle, was there any clear invasion there? Or should you comment on that, or would it just?
Yeah. Is there any scleral invasion here? So this is where the sclera begins and ends. I think there probably isn't. Probably isn't. I think that these cells here are lymphocytes. They're different to the tumor cells. And I think that we've got tumor cells in the trabecular meshwork, and that's the important thing to just point out.
Diane, can you go a little bit higher power and just point out the difference? How do you know that they're lymphocytes and not tumor cells? Because I can see little blue cells in there, and you told me little blue cells are tumor cells.
Yeah, there's blue cells and blue cells out there. So well, I'm just trying to go the closest I can. These are the tumor cells, right? And they've got little nucleoli. And they are kind of bigger than these bland, dark dots of lymphocytes. I think that some of these cells might be macrophages with pigment in them, but you can kind of see a line here where the tumor stops. You see that it transitions from one cell type to another through here.
Yeah. Yeah, so melanoma cells are much bigger.
So Zia says, I'm sorry, I missed whether it was arising or invading from the ciliary body. So I thought that it was invading the ciliary body. And in the exam, are we supposed to drive a slide viewer? At the moment, no, you just give them static pictures. But even in the static pictures, you need to use the same principles, okay? You need to look at the low power and get as much as you can from that before you start looking at the high power. Okay, should we take a 5-minute break and then carry on with retinoblastoma?
Okay.
Right, another cup of tea, everybody.
Stop recording, pause recording. Don't, just pause, don't stop.
Pause recording. Okay.
Yeah, pause, and that'll keep going then.
All right, I will pause recording. I will stop share.
Mm-hmm.
And I will.
Pathology of retinoblastoma, and just within scope is pathology, out of scope is genetics. This is what we're going to talk about. Seems like a lot, but there's only a couple of slides for each one. Starting with the question, why? Also, how to communicate with your pathologist, which is about sending specimens to the laboratory, some histopathology, the staging, which is relevant for risk factors, mimics, and other pediatric orbit tumours. Okay, chat box, please. Wake up. Why enucleate RB globes? Don't you just give them all chemo, radio, laser these days? Yeah, I'm just trying to see.
Like say the year of chemo, prognostic factors.
Okay.
Anyone want to expand?
Yeah, other reasons?
Cytogenetics, yes, to confirm the diagnosis. IRICC or above, I'm sorry, that's a clinical thing I don't understand. Prevents painful blind eye, rubeosis and glaucoma. Yep. Optic nerve spread, yep. Prevents death.
Yeah. Okay, so there's still reasons to enucleate globes besides non-surgical treatments, right? What did we think? So particularly what I see is also high clinical stage ones. There we go. And often after everything else has failed, so failure of other therapies. And the other things that you've already mentioned. Also, sometimes when those patients come from the Pacific Islands or other places and they don't have other therapies available to them, just take it out and be done with it. So there we go. But the trend is much less enucleated globes than previously. Retinoblastoma genetics, I found a nice video, so I include the link here so that you can look at that if you prefer to learn by videos. Second question. So I used to get ones and it would say I on the form as clinical information. What would you write? Besides I. Because I know it's an I. Should I write a pathology report saying yes? Left eye, that's good, Mark. What else would you like to write? Yeah, which eye is good? Laterality is very important. Okay. So nobody mentioned this. Have you had prior therapy? Because that's important, because sometimes when I open them, I can't find anything. So, and the clinical stage that you can identify is helpful too, because then I need to do a correlation with the radiologic features, because we'll come to that. So, prior therapy, clinical stage. How to send the specimen. What have we got here? This is a good job. These pictures are from actually when I worked in Sydney. So the orientation features, I kind of like an orientated globe, because how we receive them and how you take them out, there's often a bit of a difference in what they look like. And this way we can be sure that our orientation is concordant. You can, or another way is you can put a suture through one of the rectuses. However, choose a rectus that's away from the base of the tumour. Also, send it fresh and orientated. Fresh means not in formalin. Okay, now I'm going to show you a bit of technology here, which I think is pretty cool. I'm just going to try and open up this. This is, can you see my PDF now on top? Hopefully, yes. Is it moving? Okay, so this is a 3D photogrammetry of an enucleated globe, and I've opened up a scleral window, and let's have a look inside, and you can see that there is a white tumour in there. And the reason I've opened it up is so that I can sample fresh tissue from inside that globe. That's why it needs to be fresh, because the type of cytogenetics that we need to do are different from melanoma ones, and we prefer fresh tissue because we're looking for germline mutations. So after we take the fresh tissue, it gets fixed in formalin for 48 hours. So if you ring up 24 hours after you've done your surgery asking for a report, what is the answer going to be? The answer is no. Wait, don't be ridiculous. I'm going to do a good report. You have to wait till it's fixed properly because I like them to be firm before I cut them. Anyway, pathology lab handling retinoblastoma. Let's watch the video. This would also apply to many, this only applies to retinoblastomas because I'm sampling fresh tissue. First, I cut off the optic nerve margin so that it doesn't get any contamination from subsequent tumour that's going to be very liquid-like. I actually use ripple foam because it stops the globe rolling away. I've marked the superior calotte, and I'm going to cut away from the base of the tumour because I don't want to cut through the base of the tumour because I don't want to contaminate possible scleral or other prognostic factors. I make a little calotte and I lift up the window and I can see, and you can see the lens anteriorly. There's a bit of the tumour. I'm sucking out a bit of the tumour and it's a bit adherent, so I'm cutting off another piece, and then I put it into a cryo tube and it goes into liquid nitrogen and it is frozen. But often what we get is ones that are post-chemo cryo laser. And why did this one come out? Because of failure of these therapies. What's in here? So we can see little tumor seeds in the anterior chamber here. And what does it look like when I open it up? So I've opened it up and I'm looking around so I can see the uvea and there's some scarring, but actually there's no tumor mass left. There's nothing for me to take a specimen of. The only residual tumor is here in the anterior chamber. So it's good for me to know these things. You write it on the pathology request form, what you've done, the therapy, and where the residual tumor is so that I can target my sample taking. So what do globes like this often look like? So even though there's no macroscopic tumor, here we have some microscopic residual tumor and it's caught amongst the folds of the ciliary processes. It's not macroscopically identified, it's hidden. It's only microscopically identified because it's post-therapy. Okay, like the uveal melanoma, the important things for pathology are staging, as you've mentioned. We use the AJCC cancer staging or CAP protocols, and the reports that you'll be getting have a P for pathology, T for tumor stage from 1 to 4. The interesting thing to notice about the T tumor node metastasis staging is it does not mention the anterior chamber. But when we do report these, we report in a CAP protocol, just like a uveal melanoma protocol. CAP means, this is College of American Pathologists. It's the AJCC TNM classification. It's got all the rules for classification, the measurements that are meant to be taken, and that's how we do a structured report with all the staging criteria, and then there's cut up rules for pathologists at the back of it, and that's available online as an AJCC CAP protocol. And these are the things that are prognostic factors that are important that you need to be able to identify and write in your exam questions. But a lot of things we can determine at macroscopic level, which is what you see and what we see just macroscopically. So anterior chamber, nothing to see macroscopically, but clearly this is a leukocoria picture. here's my pupil optic nerve section. This one here, although it fills the posterior segment of the globe, there was a prelaminar invasion of the optic nerve, but no further invasion. So this is a stage PT2. What about this one? So this one was sent to me as a PT4 on radiology with extrascleral invasion because there was a lot of abnormality in the orbital fat, and they had thought that the tumor had got out into the orbital fat, but at operation it didn't quite seem right, so it just had an enucleation. But look how red this is. It's a very unusual looking globe. And on histology, there was scleral inflammation, which is unusual, but the stage of the retinoblastoma was PT2. There was only prelaminar optic nerve invasion. Just go down to the next. What else can we see? This different globe here. What the important part to notice here is down here. See this little dome-shaped part, white part here? It's got choroidal invasion, and I've separated it out here. The uvea is on the top, and this is choroidal invasion, which is a staging factor, makes it a PT3. The other thing it was sold to me as is possible optic nerve extrascleral. Was this tumor or not tumor? And the answer is, when I cut it, it wasn't tumor, it's just hemorrhage. And this is the...
sorry, Amanda, there's been a question on
yes.
that. What length of nerve is desirable for pathologists to have?
This is where pathologists and surgeons have differences of opinions. So pathologists would like the longest part of nerve as possible. What do you like, Diane?
So I think that I like a nerve that's a minimum of 5 millimeters.
How often do you get that, Diane?
I get that, well, with retinoblastoma, I get it more than I get with melanoma, but usually I get like 3 millimeters.
Yeah, I often get 3 millimeters and it's cut on a slant, so it might only be 1 millimeter at one end and 3 millimeters at the long end. Yeah. So why do we like a long optic nerve? Because, yeah, well, let's show you some pictures. Let's show instead of tell. This one here, what can we see? See this dark piece here? This is retinoblastoma and this is choroidal invasion. And that is a stage factor. Anterior chamber invasion, suspicious for massive choroid. So two things here. We can see there is, looks like anterior chamber fluffy tumor. And then when I cut it, we've got choroidal invasion. See the line of the pigmented, retinal pigmented epithelium. So the tumor is, this is massive choroidal invasion. And massive means greater than 3 millimeters in diameter. This is clearly greater than 3 millimeters. And it's a staging factor. It means it's a stage T 2 or 3. I always have to look up those. Here it is, T3. Choroidal invasion. And why is choroidal invasion important? Because choroid is all the blood vessels are. And that here, so this is a reason why we like a long optic nerve. How would you feel about this one, Diane?
Yeah, I would think that this was very short and there was tumor behind in that patient for sure.
Yeah, so that's why we like as long as possible. And you would already know that this tumor is occupying the region of the optic nerve. And on radiology, I'm sure that this would be suspicious for optic nerve invasion. So in this case, you'd want as long as possible. So this patient's committed to now some additional radiotherapy, etc. So yep, optic nerve, very important. So retinoblastomas, escape the globe most commonly by the optic nerve, whereas uveal melanomas don't. They escape via blood vessels. What should we mention on the histology report of interest to you? So the tumour type, is it a retinoblastoma? Here are some keywords. And then the rest is talking about prognostic factors, because really the diagnosis is not the question mark here. It's the prognostic factors, as you've mentioned in the chat. Anterior segment invasion, it's good to say present, absent. And if it's present, then you have to elaborate. Choroid invasion, present, absent. Elaborate if it's present, say how big it is. Optic nerve invasion, present if it's absent or present. If it's present, then you have to elaborate and just think sequentially. Prelaminar, laminar, postlaminar. Laminar means lamina cribosa, or at the margin, as I showed you with that PT4 case. Scleral invasion, present, absent. So the presence of, that's a silly word, the absence of involvement is just as important as the presence of involvement. It means you've considered that structure. And why do we worry? Because of progression, and because that means additional therapy is required, right? So this is what the things that we're looking for. I should have asked you the question. Anterior segment involvement, post-laminar optic nerve, and massive choroidal invasion. They all require additional therapy post-enucleation. Now we're going to talk about RB mimics, which you will know from the textbook. And I'm going to illustrate some of these for you. Okay, so we don't often get enucleation for coats anymore. Have you had any recently, Diane?
No, like not for 25 years. Thank goodness for ultrasound.
Yes, exactly. So I've had one of these. This was when I was in Sydney, and it was so rare I even sent it to Ralph Eagle just to make sure. And he said, yep. So I felt reassured. There is no tumour in here. Very unlikely. So I will briefly mention paediatric orbit tumours, which these are the three main things that you should be aware of. Notice that there is rhabdomyosarcoma, which is primary and it's malignant and it's orbital. Metastatic neuroblastoma, which is pediatric, but it's metastatic. And then the third thing is it's not a malignant tumour at all, it's hemangioma. So, and these are all common pediatric orbital things. When I worked in Singapore, I was sent a mass from the orbit of a child, and they were thinking of doing an enucleation or evisceration because of this expanding mass was actually a hemangioma. So we were able to save that one. No need to do that for pediatric hemangiomas. I think I'm going to skip now because I want us to look at the slides. Straight on to a picture of rhabdomyosarcoma, a picture of metastatic neuroblastoma, and infantile hemangioma. The reason I'm going to show you this sequence is rhabdomyosarcoma and metastatic neuroblastoma are also small round blue cell tumours, just like retinoblastoma. And they're composed of just small blue cells. But the trick is they are in the orbit. Here they are, small round blue cells, small round blue cells. And here we have metastatic neuroblastoma, small round blue cells. So it's something to consider in the differential diagnosis, although this is what you would need pathologists to do special stains to differentiate between those differential diagnoses in the orbit. This is an important one to know about pediatric orbit tumours, because this is the only time that we're going to cover this in this course. these are vascular hemangiomas. The other things that we can get is arteriovenous malformations. So these are the things that we have covered. Yep. And that's the end of this, because I want us to do some active learning. Any other questions, Diane? What's in the chat box there?
Right. Okay. No, I think that's fine from the chat box. We should get right on and go into breakout rooms and look at the slides.
Yes.
Oh, sorry, just a quick question. So how long this will take? Because there's someone waiting for me to be seen in ED. I just need to, because we meant to take a break at 11, didn't we?
Yes, we are meant to take a break at 11 and we're running over time.
Okay, so are we taking a break in half an hour? I just need to let him wait, that's all.
Yeah, so I think we'll be able to get through both these slides by 11:30 and take a break then.
Okay, and we are recording.
Okay, thanks. I'll have a presentation when I come back.
So I'm going to pause the recording now while we go into breakout rooms, and then we'll remember to start it when we come back out of them. How was that one?
We'll find out when we see the answers.
That's interesting, isn't it? We all get thrown into a different order when we return.
Yeah, you're right in the middle now for me.
Yeah. You know what we forgot to do? We forgot to ask people to sign up for Path Presenter first.
Yeah.
If they'd done the Career Cloud, they would have had to sign up for Path Presenter.
It worked when I did it yesterday, and then it didn't work today, which was weird.
Yeah, like when I do it through Career Cloud, it doesn't make me sign in because I've already signed up. But then this time it wanted me to sign in, and I can't remember.
So some of the Career Clouds need signing in, because I did the diabetes one accidentally, and that needed signing in, but the others didn't.
Yeah, we did that intermittently. Sometimes it asks you, sometimes it doesn't. So I saved the password in my.
Yeah.
It's not Career Cloud, it's the slide viewing library.
Yeah.
All right. So do you want to talk about that one? So Juliana said, were there lots of neutrophils in the tumour? So there was lots of broken down cells in the areas of necrosis, but there weren't neutrophils.
Yeah, okay, all right. I'll share screen, shall I?
All right, so guys, what did you find hard about that one? And ladies and gentlemen, I shouldn't call you all guys. It's bad habit.
To find rosettes.
Yeah.
To find rosettes? Yeah.
To be honest, I always find it hard to find rosettes. Even on the Career Cloud class, like the slides, there's well differentiated rosettes. And the question I had, how much do they spend time trying to look for rosettes?
All right. So the key thing about looking for rosettes is to not go too high. Just go to medium power so you can scan over the whole thing and recognize the little circles. Anything else people wanted to find out? Yeah, that's a good find rosettes kind of thing.
I mean, realistically, if you're given the history of the age of the patient, 0 to 1 to 2 years old, and they've got this in there, finding rosettes or not rosettes is really not the important thing.
And some retinoblastomas don't have rosettes.
That's right.
And you will be given still pictures, so hopefully they'll give you one with rosettes in.
Exactly.
Yeah.
But do we need to describe the rosette, like Alexa, Homerite? Do you need to talk about the type of rosette?
Yes, that would show your knowledge.
Yeah.
Okay.
So I found Homerite rosettes in this one.
Yes, but not flexional interstiner. But it doesn't make any prognostic difference, I jot.
So can you show us, please, the rosettes?
Yeah, well, first of all, I will start with the important things because they're not the most important things. The important things are to notice at low power, the type of section it is. So this is a pupil optic nerve enucleated globe. The anterior components appear normal, the lens is present, and the angles appear open. And at low power, I can see the optic nerve margin is clear of tumour. The sclera does not appear invaded, and there's no extra scleral extension. So I've already determined that this is not a PT4. It's probably not even a PT3 because it's not, there's no post-laminar invasion. So all of those staging factors are much more important than whether or not there's rosettes or not.
Right.
So
Jess is saying it's a large tumour and getting around the tumour on high power was hard, but I think, Jess, the trick is you don't get around the tumour on high power. You have to get around the tumour only on medium power.
That's right.
And the one message is that high power is a waste of time.
So I'm not doing anything on high power yet, and I'm just going on medium power now. And the thing that I'm noticing is the tumor location. So iris, ciliary body, and then I can see the retina is here, and then it sort of dissolves into the tumor. So involving the retina and expanding into the posterior globe, there is a tumor extending from the optic nerve head to the ora serrata involving the equator. Size measurements are not a prognostic factor in retinoblastoma, but I can see at this medium power, it's got this characteristic pattern. It's got these blue lobules of tumor. This is the perivascular sleeve pattern. Now, in order to explain that, there are these three colors that you can see. In each sleeve, there's a dot, then there's a ring of dark cells, and then there's a sea of pink material. So let's zoom in a little bit to identify what this is. So the sleeves are like a sleeve on your jersey. So in the center, there's my arm, which has the blood supply. Here's a good one. Has the blood supply. Then there is a perivascular sleeve of tumor cells because they have a blood supply. And then external to that, all of the cells out here, they're faded and pink with loss of nuclear staining. These are necrotic tumor cells. Necrotic tumor cells. So this has got a perivascular sleeve pattern with tumor necrosis, is how I describe that. That's characteristic of retinoblastoma. Regarding the rosette pattern, I'm just looking around here. Some of these little holes are actually due to apoptotic tumor cells. You will see better rosettes, I think, in pictures in the textbooks. This one's not a particularly rosette type of tumor.
I found some quite good ones at about 10 o'clock near the coral.
Go down.
Low power, you can kind of see them appearing as regular little holes. That's
down here might be the area. Oh yes, these are lovely rosettes, Homerite rosettes. So here's a rosette of retinoblastoma cells, and there's lots of fibrillary fibers all pointing in towards the center. These are back-to-back rosettes, and they don't have a central lumen. So these are Homerite rosettes, no hyphen in between the Homer and the right, because it's not two people, it's one person. That's his name, Homerite. Homerite rosettes. Yes, this is a good Homerite rosette pattern. The other things that we want to identify are the prognostic factors. So that would be choroidal invasion and optic nerve invasion. So I'm going to have a look.
Subtle in this one, actually.
Chris and I looked quite quickly for choroidal invasion. So I'm looking at the choroid here where the vessels are to see if there was any choroidal invasion. What did you see, Diane?
If you keep scooting along, I thought it was very early choroidal invasion.
Oh, could be.
Just there.
Yes.
Yeah.
So we didn't spot that before, but there we go. So here we have some retinal pigment epithelium. Yep. And deep to that. So this part is choroidal invasion. Clearly it's less than 3 millimeters, so it's not massive choroidal invasion.
And the other thing that people sometimes comment about is subretinal invasion. And there's definitely subretinal invasion here. In fact, if you go to the other side of the optic nerve, nice subretinal invasion, and also some nice retinal metastases too. So if you go,
So here's nice retina. Okay, down here.
Yeah, so those cells deep to the photoreceptor,
Retina.
subretinal invasion, but probably not through Brooks membrane.
Yeah, so that looks like a bit of retinal pigment epithelium left there.
Yeah.
And here's retina. These are tumour cells, subretinal invasion. Let's talk about the optic nerve and optic nerve head. Okay, so here we have axis of the optic nerve, and here's the central retinal artery and vein. And I was using the annotate feature, which I'm trying to find. So lamina cribosa, I would probably draw the line for the anterior part. See how the optic nerve fibers, as they pass through the sclera, there's sort of a waist shape as they go through. And so lamina cribosa is the sieve-like part of the sclera where the optic nerve fibers pass through. And this is an anatomical landmark. And so we have optic nerve head here. And if I just, let's see if I can draw the drawing here. Draw. So let me see. What do you reckon? Oops, a bit wobbly. What do you think about, yeah, anterior, so lamina cribosa about here.
Yep.
So is there invasion of the optic nerve head pre-laminar? What do you think, team?
Yes.
Yeah. So I'm suspicious about all of this tumour here,
like,
all of this tumour here, this tumour here. So I would call this pre-laminar optic nerve invasion. The laminar, no. Post-laminar, no. So pre-laminar optic nerve invasion, that's an important prognostic feature thing.
So Chris has said, my understanding that sub-RPE invasion without extending through Brooks didn't qualify as choroidal invasion. No, so you don't have that the wrong way around. So it has to go through Brooks to be choroidal invasion, but sometimes it's hard to see. Yeah, so it has to go through Brooks membrane to be choroidal invasion, but it's worth reporting anything that you notice, sub-RPE, but not through Brooks, subretinal, but not through, the RPE, yeah.
That's what we're looking at there.
You can, yeah.
So you can see most of the prognostic factors were you can actually determine at medium power and low power, except for that little bit of choroidal invasion there and confirming the pre-laminar optic nerve invasion. Absence of anterior chamber.
Diane, just a quick question about the margin of the tumor. The cells just arises just behind the lens, and what are these?
So there's vitreal metastases there.
Yeah, vitreal seeds. Is the other words.
And are they like they're prognostically important?
They are definitely prognostically important.
Yeah. So there's probably collapsed vitreous material here.
Yeah, and then it's growing a fibrovascular membrane and seeding along it. Yeah, through there.
A nice little seed here. Which is the opposite of the sleeve because it's necrotic in the center.
All right.
There's another seed. Okay.
So is this an exophytic rather than endophytic? Okay, so we use the same terms for retinoblastoma. This is endophytic. It's growing endo. That
direction. Which is usually associated with vitreous seeds, whereas the exophytic ones going out that way are associated with larger choroidal invasion.
Yeah. Okay. We need to take a longer break now until 12 o'clock. So the other slide is a really straightforward hemangioma. So have a look at it later. And we'll see you. Go outside. What time should we come back, Amanda?
Let's see. I've just lost my program.
We should be
That's
back
right.
at 12 because I'm overrun as usual.
Yes, okay. Yep, start at 12.
At 12.
Okay.
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 See you all later.
See ya. Oh, stop record.
Yep. Stop recording.